Good afternoon, everyone, and I welcome you all to the 101st session of our e-NISCHIT. And it's a new beginning, but our conviction and determination remain the same of knowledge building and capacity building for all of us here. All, even the people who were for the experts, for the presenters, and the audience as likewise. All of us are going to learn. All of us learn very new things in each and every session. I'm very sure about it. So that's the basic essence of our e-NISCHIT clinics, and I welcome you all. Very hearty welcome to all of you, my friends from Madhya Pradesh, Tamil Nadu, Assam, Nagaland, Tripura, Sikkim, and other states who have joined us. Thank you very much for joining us today. So to begin with our session, and I would first like to introduce my panel members to you. So as I said that our session is all about knowledge enhancement and capacity building, but knowledge is such a commodity that is just a button away now. We all have smartphones. So why do we need these sessions? But we in fact we need these sessions even more because we half-baked more knowledge is more dangerous, or ill-fed knowledge is more dangerous than having no knowledge at all. So that's why we make our own endeavors to make these specially curated sessions for all of you and for all the people who are working at ART centers, and we do our best of effort to get the best experts on the panel for you people. And so, on that note, I'm very happy to introduce you our expert for today, Dr. Ashish Ranjan. He's a senior chest specialist at our institute, National Institute of TB and Respiratory Diseases, and he has an immense experience of over 8-9 years in the all kinds of chest diseases and tuberculosis especially. So we are very fortunate to have him, sir. Thank you for joining us today. And apart from the expert, we have our other panel member, Dr. Jyoti from India. She's the chief coordinator for all these sessions. And we have our people from Eco India, Rakesh and Shifa, who help us with the logistic part. So now that we have begun the session now, so next, our today's case presentation is by Dr. Tanweer Ara, who is a medical officer at GTBH Hospital, Delhi. But before she presents the case, a little bit about the case. So today's case is about basic TB management in it, basic TB management and guidelines and what to follow and what to have in mind. And in a case of HIV in this case. So it is about going back to basics, and it's about getting your your knowledge at the basic level clear, and what are the recent guidelines, incorporating that so that we can make the best management decisions. So we have taken a case in which is TB HIV case, and our case presenter for today is Dr. Tanweer Ara, medical officer. Thank you very much, ma'am, for sending us the case, and we can have the case presentation now.
Good afternoon, everyone. Thank you so much, ma'am, sir, and Dr. Jyoti. Thank you so much again. Because of your help and support, today I'm presenting this case. Actually, this patient recently diagnosed HIV positive last year, I think July 2022. When he came to our ART center for HIV initiation, he came with a few investigations like blood test, CBNAT, sputum for AFD, and chest X-ray. And also he complained about fever, cough, weight loss, loose motion. That's why we didn't initiate ART that time because his CBNAT and sputum for AFD was negative. But chest X-ray showed nodular opacity in both sides of lung. Also, there is an enlargement of lymph node in paratracheal region. That's why we didn't initiate. CBNAT was also 2 months back. So I advised him kindly do fresh CBNAT and further CECT chest. Then when he came back again with CBNAT and CECT chest report, his CBNAT was again negative. But CECT chest showed multiple necrotic lymph nodes all over chest, like both sides of cervical region, paratracheal region, retrotracheal region, all over thoracic region. So on the basis of patient symptom, because he complained about fever, loss of appetite, and almost 3-4 months, that's why on the basis of patient complaint and CECT chest, we initiated ATT on 5th of August. 2022. After 2 weeks of ATT, we initiate ART with TLD plus DTG regimen. On 22nd of August 2022. His baseline CD was 231. After 7 months of ART and ATT also, patient viral load become PND, and his CD4 little bit raised from 231 to 278. So during this 7 months of course of ATT, patient in every visit patient complain about cough. He don't feel to eat anything. We did LFT also, but his LFT was totally normal. During all 7 months, he was not improved so much. Then on January, we advise again for CBNAT and chest X-ray. This time CBNAT came positive and rifampicin sensitive. And X-ray also showed few opacity, fibrotic change also, but opacity also seen. That's why we decided to reinitiate ATT on 25th January 2023. Right now, patient completed almost more than 7 months again, and in last 2 visit, patient improved so much, ma'am. Not like previous situation, like last 7 month ATT. This 7 month ATT, during 4th, 5th CP, he improved so much, ma'am. And his chest X-ray also improved. Looks like a very normal X-ray. So now we advise him for CECT chest for further clarification, because he complained only occasional cough, not regular, but mild occasional cough. So now I want to know, can we stop ATT because it's almost more than 14 months? Can we stop on the basis of his improved symptom and chest X-ray, fresh chest X-ray, and now he is asymptomatic? So can we stop ATT, or should I wait for CECT chest report? This is all what I need to explain about this patient.
Thank you so much. Thank you so much, Dr. Tanweer. Indeed, it's a very interesting case to discuss, because this is a case scenario which we see in almost every 4th case in our ART centers. We have the same diagnostic and management dilemmas. And especially when we are dealing with TB and HIV, then there are more than multiple issues to deal with. Because if we are dealing with just a TB in an immunocompetent patient, we can just say, okay, the patient is not responding, so maybe TB drugs are not working. Is there a drug resistance? But in case of HIV, then there's a you open the Pandora box, because there can be multiple reasons for non-responding. So to begin with, to go with first, I will just summarize the case a little bit. So you have told the case very clearly, in a simple case. I'm sure all of us got it. It was a case in which recently diagnosed HIV patient was put on ATT on the basis of CT scan and symptom, and the CT revealed multiple necrotic nodes. And the patient, and after 15 days, ART was started. But the patient, the first 7 months that he was put on ATT, he was not responding so well. So when he came back to the ART center, it was rightly put, the ATT. A quick comment. Then, after 7 months, when the patient came back to the same ART center, and they thought they didn't see any clinical improvement, or patient was so symptomatic, so they repeated the investigation, and they found the CBNAT was positive, MTB positive, and insensitive that time, and so they reinitiated the ATT. And this time, after reinitiating, the patient chest X-ray improved, and he's asymptomatic. So now they are waiting for, I think they have done the X-ray also, so X-ray has improved. So now their dilemma or their question is that what went wrong, or can they stop the ATT now on the basis of clinical improvement? So what I was saying, that it's an immunocompetent host, like I said, things are simpler, but when it comes to HIV, then there are multiple things to think of. And so the first thing, obviously, we should check is whether the patient was compliant, whether he actually did take ATT or not, that he was not responding. Common sense is the most important sense. So first thing is we have to check the compliance of the patient, and we have to make sure that whatever we are labeling the patient of, but first we have to ensure that he is taking the treatment, because this is a very, very common problem, especially in HIV patients who have such a big pill burden. And secondly, it could be natural history of disease, or it could be a very a syndrome which is called immune reconstitution inflammatory syndrome, which is seen and very commonly in HIV patients, in which when the immunity gets built up and then the patient starts, there's exaggerated immune response, so there's exaggerated symptoms of the clinical or subclinical infections that we have. So that it could be part of that, or it could be our HIV drugs are failing, which looks unlikely in this case as the virological load was nil, or it could be, could it be India? Very difficult to say because we have been monitoring this patient radiologically and there were no cultures. So why it did not respond in the first time and why it did not respond in the second time will be, I'm sure all these questions we'll be able to address better after we have our session by our directly by our expert today. So I would like to now hand over the mic to our expert today, Dr. Ashish.
Thank you, ma'am. Well, good afternoon, all, and thank you, Dr. Ananya, for nicely introducing me, and Dr. Jyoti from the CR India and our ECO representatives. So today I am going to talk about management of HIV TB cases, and in that process I will also address the relevant questions which were raised during the case presentations. So here is my presentation. So as we know that people living with HIV are 18 times more likely to develop active TB disease than people without HIV. And opportunistic infection, if we consider that TB is the most common in the PLHIV, and it is primary and leading cause of its related death among PLHIV. So India accounted for an estimated 71,000 incident TB patients among PLHIV in 2019. We know that TB accelerates HIV disease progression, and HIV paves the way for clinical TB and mycobacteremia. So though both are very interrelated. So for this, we have to diagnose early. We should give effective TB treatment, and there should be prompt linkage to HIV care and early initiation of ART and TPT. And these are the key factors which can reduce the negative impact of TB in PLHIV patients. So here is an algorithm which is the NTP guideline, based on which we can diagnose a PLHIV patient for TB. So any PLHIV patient with 4S symptoms, we consider it presumptive TB, and it should go NAT test, either CB-NAT test or true NAT test. So in HIV cases, usually in normal cases which are immunocompetent, usually these patients are diagnosed by the smear. But in PLHIV cases, we do upfront NAT test. So CB-NAT or TrueNAT can be used for diagnosis. For this, appropriate specimen should be available. So in the algorithm part, we can see two parts. One is the left part, one is the right part. So in the left part, when a patient comes NAT positive for MTB, and if the rifampicin is sensitive, then we have to start the anti-TB treatment at the ART center, and we have to send sample for first line probe assay. So because rifampicin sensitivity can be assessed by the NAT test, but for isoniazid we have to send the line probe assay test. And if patient comes RIF resistant in the CB-NAT test, then it should be referred to the DRTB center for initiating the appropriate DRTB regimen, or meanwhile the first line LPA, second line LPA and liquid culture DST should be sent for that patient. In the right part, you can see that if NAT is not feasible or NAT comes negative, and still you think that patient is TB, then you evaluate the patient with appropriate diagnostic tools like chest X-ray, ultrasound abdomen. So basically, negative NAT test does not rule out TB. Obviously, we have to see the clinical scenario as well. So based on the X-ray or ultrasound or other investigations, if TB is diagnosed, then we have to start the ATT at the ART center. And if TB is ruled out, then we have to evaluate for alternate diagnosis. So we can frankly say that in the HIV cases who are 4S positive becomes presumptive TB cases, they should undergo the NAT test. They should not be offered the can be offered the smear test, but upfront NAT test should be done. And if NAT comes positive, then and RIF sensitive, then we should start the drug sensitive TB regimen. If RIF resistant is there, then we should start the DRTB regimen. But if NAT comes negative and still we think clinically that it is TB, so it does not mean that patient has patient had not TB. So we should go by the other investigation tool like chest X-ray and ultrasound and other tool. So that we can diagnose the TB. So that TB is diagnosed as clinically diagnosed TB. So patients who are CBNAT positive become microbiologically confirmed, and who are diagnosed by the other tools, they are clinically diagnosed TB. So for managing TB, we have to essentially understand the concept of drug resistance. So two things: drug sensitive TB and drug resistant TB. So drug sensitive TB is a case in which the isolated MTB is susceptible to all first line drugs, that is rifampicin, isoniazid, pyrazinamide, and ethambutol. In drug resistant TB bacilli is resistant to one or more anti-TB drugs. So there are multiple definitions like MDR TB, pre-XDR TB, and XDR TB. So what is MDR TB? So MDR TB is a subset of drug resistant TB wherein the TB bacilli are resistant to at least isoniazid and rifampicin. So isoniazid and rifampicin resistant TB is called multi-drug resistant TB. What is pre-XDR TB? So pre-XDR TB is the MDR TB case with additional resistance to fluoroquinolone. And what is XDR TB? So XDR TB is extensively drug resistant TB, in which there is a MDR TB case with additional resistance to FQ and along with one or more group A drugs, bedaquiline or linezolid. So basically for BRTB, there are multiple groups A, B, C. So from group A, there are three drugs, FQ, bedaquiline and linezolid. So if MDR TB is if the MDR TB is present with additional resistance to FQ and one or more group A drugs like bedaquiline and linezolid, then it is called XDR TB. So all the PLHIV patients who are diagnosed with DRTB should be sent to the DRTB center for management of TB. So for drug sensitive TB, this is the NTP guideline in which we give the FDC, that is the fixed dose combination drugs. So it consists of isoniazid, rifampicin, pyrazinamide, and ethambutol in the first 2 months, and in latter 4 months, it is isoniazid, rifampicin, and ethambutol. So total 6 months of treatment we usually give in the drug sensitive TB cases, and there is a daily dose schedule as well for the adults, and it is given as per weight bands. So this is the NTP guideline. You can get it from any NTP guidelines. So this is the treatment regimen, that is the 6 months of treatment with 2 months of intensive phase and 4 months of continuation phase. In the intensive phase, we give the 4 drug combination FDC, and 3 drug FDC is given in the latter 4 months. And the below chart, below table shows the weight band categories, and according to weight band categories, we give the tablets 2, 3, 4, or 5 tablets. And in more than 75 kg patients, we give 6 tablets. So during the treatment part, we follow the patients every month. Along with during the follow-up, we should ask about the adverse effects also. So little about the adverse effect, important adverse effect I am discussing. So for all the first line drugs, for isoniazid, the skin rashes are important, peripheral neuropathy, hepatitis. So these are important adverse effects we should ask patients about. And then the rare effects which we can see is psychosis and convulsion. So though these are rare, but these are very dangerous side effects. So we should always aware about it. So isoniazid can cause psychosis and convulsions, and we usually see these kind of patients. Then the rifampicin. The rifampicin, the common side effects are gastrointestinal. Most of the patients will present with abdominal pain, nausea, and vomiting. And if rifampicin also causes hepatitis. So these adverse effects should be kept in mind while treating. Then the pyrazinamide. For pyrazinamide, arthralgia is important and hepatitis is important. And for ethambutol, it is retrobulbar neuritis. So it is not very common, but it is a life-threatening, and it is actually patient can lose the sight. So ethambutol causes retrobulbar neuritis as soon as patients complains of the some problem in vision. We should refer the patient to the eye specialist, and we should stop the ethambutol unless the eye specialist says that this is not related to ethambutol. So after starting the treatment, we should follow the patient every month, and the follow-up should be closely monitored for treatment response as well as disease progression. So basically, there are two components of follow-up. For the our case also, it is very important. There are two components of follow-up. One is the clinical follow-up and one is the lab follow-up. So for clinical follow-up, patient should be followed up every month at your center by the MO. So what we see in that follow-up, we see the improvement on the clinical symptoms like 4S symptoms. We also see the increase in weight, and if weight is increasing, is a good prognosis. Then with the help of other relevant investigations like radiology or with abdominal boxes there, then we can go for the ultrasound abdomen. So with the help of the other radiological and relevant investigations, we can also follow the patient for the improvement. And during the follow-up, we should also ask about the comorbid conditions like HIV and diabetes by appropriate treatment. Suppose if patient is diabetic, then we should go for the HbA1c and RBS for seeing the control of the diabetes, because if diabetes is not controlled, then TB may not be TB disease may not improve. So symptoms and signs of adverse drug reactions may also be asked during the follow-up. So clinical follow-up is very important. Every month we have to do the follow-up of the patient. We should ask about the clinical symptoms for which we have started the treatment. We should ask about the weight gain. We should ask about the comorbid conditions like diabetes, and we should ask about the adverse reactions. And at the same time, we also go for the radiological and other relevant investigations like chest X-ray for seeing the improvement in the disease. So I was talking about the clinical follow-up. Now I will talk about the laboratory follow-up. So in case of pulmonary TB, we should offer sputum smear microscopy at the end of intensive phase. That is when you are giving the 56 dose of the TB treatment. At that time, you should give a sputum cup to the patient, and he will give his sputum, and he will get the results. And then at the end of treatment, so the CP is of 112 doses. So preferably, we should give the sputum cup at 108th dose of the continuation phase. So when during the IP, we go for the sputum smear microscopy at the end of IP, and we start the CP. So we give the sputum cup and start CP after the IP. If a sputum smear microscopy comes negative, then it indicates a good prognosis. If at the end of IP sputum result is positive, then CP will be started, but DST results, according to DST results, we should offer the modified treatment. So what happens when sputum comes positive at the end of IP? We should send the patient for CBNAT again, and as well as we should send the patient for the LPA and liquid culture. So based on that, we will have a profile of drug sensitivity, and based on that, if we can modify the treatment of the patient. But if the sputum is negative, we should continue with the continuation phase of the drug sensitivity. So at the completion of treatment, again, we should offer sputum smear or culture for every patient. We should offer, and the follow-up sputum smear examination at the end of treatment is very important, because of we should evaluate the result of the treatment. So, however, in the presence of clinical deterioration, the medical officer may consider repeating sputum smear microscopy even during CP. So ideally, we should send the sputum smear at the end of IP and at the end of CP. But in between also, based on the clinical scenario, medical officer can order a sputum smear microscopy as well as CBNAT. So because during CP, patient is deteriorating, we cannot wait for the 4 months. So we have to do the smear early. So because it will provide the patient an additional opportunity to undergo drugs susceptibility testing if he or she is found to be sputum smear positive. So if patient comes sputum smear positive in IP or CP, he will be offered CBNAT and LPA test as well as culture DST test. So other investigations we can offer to the patient for the follow-up is the chest X-ray. It is a good tool to assess the progress of clinically diagnosed TB case, and it is to be offered whenever required and available. For drug-resistant TB, it may be carried out at end of IP, end of treatment, and whenever required. And in extrapulmonary cases, the response usually best seen clinically. And in extrapulmonary cases, we should take the help of radiological and other relevant investigations. However, we do the sputum smear as well as sputum culture, but CBNAT we should not order for a follow-up sputum examination. So why it should not be ordered? Because it can pick up genes of dead MTB to give positive results. So it is also relevant related to our case also, that we should not follow a patient by CBNAT at the end of the treatment, because if positive results come, it does not signify anything, because it can pick up genes of dead MTB to give positive results. So we should follow the patient clinically and by laboratory investigation. In lab investigation, we should offer sputum smear and sputum culture, not CBNAT. So another thing is the outcome of TB treatment. So what outcome of should be assigned to a TB case when he is treated by a appropriate regimen? So there are multiple outcomes. One is cured. So the definition of cure is that whenever a microbiologically confirmed TB patient has been initiated on the TB treatment, it should become smear or culture negative at the end of the complete treatment. And so cured should be defined only by the microbiological confirmation. Patient should be microbiologically confirmed at the initiation of the treatment as well as at the end of the treatment. It should be microbiologically negative. And what is the treatment completed? So a TB patient who has completed treatment without evidence of failure or clinical deterioration, but there is no evidence of smear or culture result because either it is not done or completed, we can assign the outcome treatment completed. And the patients who are initiated based on the clinically diagnosed TB, they are also treatment completed, because at the end of the treatment, if there is no positive smear or culture and they have been initiated based on the clinically diagnosed TB, then the outcome is the treatment completed. And the cured and treatment completed combined is the treatment success. Third is the treatment success. So cured and treatment completed is combinedly called treatment success. Now failure. So it is also related to our case, because in the case we saw a failure. So what is failure? What is the definition of failure? So failure, a TB patient whose biological specimen is positive by smear or culture at end of the treatment is failure. So either by the smear or culture, not CBNAT. So a patient, we can assign failure if patient received 6 months of treatment and at the end of the treatment we order a smear or culture and it is positive, then it is failure, but not CBNAT. So we should not assign failure outcome to a patient who is positive, comes positive on the CBNAT at the end of the treatment. So it is very well clear that failure is defined only by the smear positivity or culture positivity at the end of the treatment. So two words are important: smear, culture, or at the end of the treatment. Then another is the failure to respond. It is more for the pediatric TB cases in which there is microbiological conversion to negative status and who fails to respond clinically or deteriorates after 12 weeks of compliant treatment, he should be assigned as a fail to respond. Then there is a loss to follow-up, and a patient whose treatment was interrupted continuously for 1 month or more is lost to follow-up. A patient who is transferred out and the outcome is not assigned is not evaluated. And then another is the treatment regimen change. So at the end of treatment or in between, if you go for the CBNAT and you found that there is a drug resistance, then you change the treatment from drug sensitive to drug resistant regimen. So in that cases, you assign the outcome treatment regimen changed. And the patient who died because of the TB is during the TB treatment, the outcome should be assigned as died. So failure, definition of failure is very clear over here, that a TB patient at the end of treatment should be positive by the smear or culture. So he should be assigned as failure, not by CBNAT, he should not be positive. So something little about ART, already you know much about ART, but for the all PLHIV diagnosed with active TB are to be initiated on ART regardless of CD4 count. ART should be started as soon as possible within 2 weeks of initiating TB treatment. ART regimen in PLHIV receiving first line anti-TB treatment as per NACO. So first line ART is 2 NRTI along with 1 integrase strand transfer inhibitor. So dolutegravir based regimen with NRTI backbone is the preferred regimen for all PLHIV on first line ATT. So DTG based regimen should be offered for all HIV patients who are initiated on ATT as well. So we should know about the interactions because we are starting 2 regimens. One is ART regimen, one is ATT. So we should know the interactions. So in the first line we have isoniazid, rifampicin, pyrazinamide, and ethambutol. So rifampicin, as we know, is a potent inducer of drug metabolizing enzymes and drug transporters, and co-administration with DTG reduces the bioavailability of DTG, which can be overcome by doubling the DTG dose to 50 mg twice daily. That's why you already know that you always add 50 mg extra DTG in these patients who are HIV TB. So till the completion, you along with the ATT, you add extra 50 mg of DTG in the TLD regimen. Once the ATT is completed, an additional tablet of DTG 50 mg should be stopped 2 weeks after the stoppage of the rifampicin containing treatment regimen. And again, the rifampicin is a cytochrome P450 enzyme inducer and suppresses the bioavailability of protease inhibitors, thereby decreasing the efficacy of ART. So the patients who are on protease inhibitors should not be offered the usual ATT, that is the rifampicin based. So in that cases, we should offer rifabutin in place of rifampicin, rifabutin 150 mg for the entire course of ATT. So 2 things are important over here. For ATT in which rifampicin is there and you are giving TLD, you should add DTG 50 mg extra for whole course of the ATT along with the more 2 weeks. And for those patients who are receiving the protease inhibitors, we should not add rifampicin in the ATT. We should add rifabutin in place of the rifampicin. So these are 2 important things which we should know. So these are the already you know that I am not going to discuss it. These are the recommended ART regimens in PLHIV infected with the drug sensitive TB and receiving rifampicin containing anti-TB regimen. So preferred ART, you know that this is TLD. So basically we add 50 mg extra DTG in these cases, and in cases of the where we boost the treatment with the PI protease inhibitors, we should replace the rifampicin with the rifabutin. So what is ART failure? So we talked about the ATT failure, now ART failure. So what is ART failure? So when a patient on ART presents with active TB, it is actually in scenario of TB actually infection. It is not actually the ART failure. I'm not. It is in scenario with the TB. So when a patient on ART presents with active TB, there is a possibility of suspecting treatment failure, that is ART failure. So NACO recommends the following guiding principles in this context. So if an episode of TB occurs within the first 6 months of the initiation of ART, it should not be considered a failure of treatment, and immune reconstitution inflammatory syndrome, that is IRIS, should be suspected and managed accordingly. And if an episode of TB develops more than 6 months after the initiation of ART, PLHIV should be assessed for the possibility of ART failure based on the CD4 counts and viral load with a special focus on adherence. So 2 things are there. If a patient is on ART, within starting ART, within 6 months of starting ART, if patient develops TB, then don't suspect it as a failure. You also you should suspect a IRIS, that is the immune reconstitution inflammatory syndrome, because after giving the ART, the immunity of the patient improves. That's why because latent TB may have occurred. And then after 6 months of ART, if patient develops TB, then it is the possibility that there is a ART failure. So there is a distinction between the ART failure versus IRIS in these scenarios. Then DRTB, a little about the DRTB and HIV. So what is the principle of treating DRTB in PLHIV? So we should initiate appropriate second line anti-TB regimen depending on the drug sensitivity profile. And we should also start ART as early as possible, preferably as soon as ATT is tolerated, maximum within 2 weeks. And as we know that HIV infected DRTB patients without the benefit of ART may experience mortality rates up to 90%. So when choosing the drug regimens, important thing is that we should keep in mind the drug-drug interactions between the second line drugs and the ART. So certain combinations have to be avoided. Yeah, used with caution. We will discuss in the next slide. So what is the best treatment, best ART regimen for the DRTB cases? So usually in DRTB we usually give the bedaquiline based regimen or bedaquiline based regimen nowadays. So in those cases, dolutegravir based regimen, DTG based regimen, ART regimen is the best choice. So these are the regimens for DRTB and HIV. For H monopoly, the H monoresistance TB, we usually give 6 months of levofloxacin, rifampicin, ethambutol, and pyrazinamide. Because H is resistant, so we exclude the H. For MDR-TB, we have a 2 regimen. NTAP offers 2 regimens. One is the shorter oral bedaquiline containing regimen, and another is the all oral longer MDR or XDR-TB regimen, which is for 18 to 20 months. So we will not go deep inside it because DRTB persons usually manage that. Then the drug interactions we should know about. So for example, if you are giving ritonavir to a ART patient, to a HIV patient who is also on the bedaquiline based regimen, so it can increase blood levels of bedaquiline. So we have to very cautious about the drug toxicity. Therefore, intense monitoring should be done for adverse drug reaction in these cases. So patients who are on a ritonavir based regimen should and receiving bedaquiline, so we should cautious about the drug toxicity. And then some patients may be on the efavirenz based treatment. So efavirenz reduces the blood levels of bedaquiline. So it may decrease the efficacy of bedaquiline. So we have to be very cautious about it, ritonavir and efavirenz. Then the linezolid. Linezolid is also the part of the drug regimen. So linezolid requires close monitoring for bone marrow suppression because it causes bone marrow suppressions, and zidovudine also causes it. So when co-administered with zidovudine, we should take a special precaution, and complete blood count should be performed regularly. And then the DRTB also contains the fluoroquinolones and clofazimine. It increases the risk of cardiotoxicity when co-administered with bedaquiline. And so bedaquiline, clofazimine, and FQs, they all can increase the QT interval. So QT prolongation can be, and also QT prolongation can be done by the fluoroquinolone, clofazimine, and bedaquiline. And in ART, ritonavir containing regimens can also cause the QT prolongation. So we have to strictly monitor these patients who are on the FQ, clofazimine, bedaquiline, and as well as on the ritonavir containing regimens. So these are important drug interactions we should keep in mind so that beforehand we can take precautions. So this is the end of the slide. The take-home message is the TB is leading cause of AIDS-related death among PLHIV. Early diagnosis, effective TB treatment, and early initiation of ART is important. The NARD test should be used upfront for diagnosis in HIV cases. It is more sensitive and tells about rifampicin resistance at the same time. Management of drug-sensitive TB and drug-resistant TB with appropriate regimen is necessary. Follow-up should be done clinically, radiologically, and microbiologically, but CBNAT should not be used as follow-up test. DTG-based regimens are preferred in HIV TB cases. Drug interactions happen, so accordingly modifications in either ART regimen or ATT or both to be done. Adverse effects are manageable but requires a close monitoring. Thank you. So in context of the case, I can say that the treatment was initiated, and at the 6th month, because the patient was a case of disseminated coughs, he has a pulmonary TB, mediastinal lymph nodes, cervical lymph nodes, hepatic granuloma, and splenic granuloma on the CT. So it was a disseminated cough. So patient at the 6 months of the treatment, patient was symptomatic because in disseminated cough sometimes we have to extend the treatment. Though it cannot be a classical failure, but the extension of treatment may be required in these cases because the TB is more and in many part of the body, many organ systems. So we require extension of CP phase up to 6 months or 3 months. So it is not a classical TB failure case because based on the CBNAT we cannot say it is a failure. And another thing is if patient was symptomatic at the end of 6 months, then it may be because the patient was a case of HIV and there was a disseminated cough as well. So with the improvement of the CD4 count, patient may have improved, and because ART was also started only 6 months back. So with time he has improved. So it is, in my opinion, it is not a classical failure case. It is actually we have to extend the treatment. That's why he is improved after the extension of the same treatment. So usually in our practice, we extend the treatment for especially mediastinal or lymph nodes or for disseminated coughs. We usually extend continuation phase of the treatment for 3 months or 6 months. So in these cases, when the patient was started in the August, so we should have to be extended the CP till the prior. So it is not a failure case. Obviously, the extension was required, and that's why the reinitiation reinitiation benefited the patient. Thank you.
Thank you, Dr. Ashish. It was an excellent presentation, and it spoke volumes of your expertise and acumen in this field. And I'm sure all of us are going to benefit a lot from it. There are a few questions that the audience have asked. So, I will ask Dr. Jyoti to read.
First. So this question is for the expert. What if the patient don't have cough at the end of the second IP and at the end of the continuation phase? Still, should we have advice for the sputum or AFP?
So thank you for the very good question. So usually patients present to us for after 2 months or at the end of treatment, they say that I am absolutely fine. I have no cough. I have not no expectoration. So what should I do? So usually we advise that with certain maneuvers you can produce cough because sputum. Because in normal persons also there is in the morning sputum comes sometimes. So we usually advise for some steam inhalation and some warm water or hot water in the night and in the morning. Then after a deep breath, he takes the deep breath and try to cough and expectorate. Despite that, some patients in this maneuver, some patients succeed and some patient does not succeed. So in those cases, we have to follow up by the clinical scenario as well as by the radiological or relevant clinical investigations. Hope I answered the question.
There was one more question for the case presenter. Was the DST or LPA done for this case?
No, ma'am. DST we didn't advise because previously we advised for CBNAT. It was RIFA sensitive. That's why we didn't advise for a DST test.
Okay. And for the other clinical details, do you have, Dr. Tanweer?
Ma'am, his weight was previous 41, I guess. Now he almost gained 10 to 11 kg weight.
Is there any more questions from the audience?
Okay, as I understand, so what?
I have a query.
Yes, please.
Ma'am, since the DST and LPA were not done, and patient is turned out to be a disseminated Cox case in his second episode, probably the patient is going into immunosuppression and ultimately might lead to his viral load failure.
Okay. So should we wait for CCT test again, sir?
Let us first address one question at a time. So the first question that came was by Dr.
Sachin.
Sachin. So you are asking that you are saying that this time CBNAT the report has come positive. So now that means the patient is going for immune suppression and it will lead to viral load going high. So that's a very good question and I would like to clarify this question.
Okay, so I think in opposite way because the patient has after 6 months of ART, patient has reconstituted his immunity. So that's why in that cases also, because usually we see that with less CD4 count and more immunosuppression, usually they are atypical cases and they usually does not come positive. In HIV usually we see, in HIV TB cases usually we see that if there is more immunosuppression, less chances of sputum positivity or TB positivity. So as the immunity improves with the ART, then it is more chances that they come positive. So that's why his immunity has been improved in the January. That's why his CBNAT comes positive. But that does not signify that treatment is failed because the patient was the X-ray. When you see the overall case in the August 2022, the patient's X-ray has nodularity, it has bronchiectatic shadows, but in the January X-ray, only fibrosis is there. Fibrosis is the sequelae of TB, not is the active TB. So, as per the X-ray, patient was improving in the January, as well as clinically, actually, the patient is not improving because in disseminated coughs, sometimes we require more treatment. But obviously, the patient was improving on that ATT and ART as well, because in the X-ray, as compared to the X-ray of the August, the Jan X-ray was much improved, and there was no actually nodularity and no bronchiectatic shadows. Only fibrosis was there and reticular pattern was there. So fibrosis and reticular pattern are basically sequelae of TB. They are not active TB findings in the X-ray. First thing. Second thing, because we don't have the smear or culture in the January, so we cannot say that patient was failing or patient was not responding because CBNAT can pick up the dead bacilli. So the CBNAT was negative. It may be because of the sputum quality or maybe because of the immunosuppression at the time of initiation of the treatment, the CBNAT was negative, smear was negative, and in the January CBNAT comes negative. But the CBNAT come positive later as well. Up to 2 years CBNAT can positive despite the treatment because CBNAT can pick up the dead bacilli, genes of the dead bacilli. Hope I answered the question actually.
Yes, Dr. Ashish, thank you for throwing light on this very important aspect, which we see in HIV, that as the immunity builds up, the more the symptoms, the more the signs they show. So that doesn't mean they are failing. It's just that the immune response is able to show up the symptoms and signs of the infectious disease that they are carrying. So it is very important to remember that there are three kinds of failures. There are clinical failure, there's immunological failure, and there's virological failure. So when the patient is immunologically improving, but you think that the patient is not improved clinically, up to you. Like you think that in this case, when the viral load had become negative and the CD4 was good and it was less than 350, but clinically the patient was not improving according to you. So it could be it is clinical failure. It is not the disease failure. So it could be something like iris, or it could be just something like a natural history of disease of the patient. Because like Dr. Ashish rightly said that the CBNAT could have just picked up the dead bacilli and the disease was naturally getting cured. But it's just a slower response because it was HIV. Only when it's clinical failure also and immunological failure also, like the viral load is also going rocketing and CD4 counts are going low, then we think that, oh, now if the patient is going immune suppression, we have to understand that concept of separating the clinical failures and immunological failures and understanding what is failing at what time. And sometimes we see patients fail having no clinical improvement and we don't have the immunological state of the patient. Then that's where when we think of drug-resistant TB and we try to put the blame on the TB, maybe there's drug-resistant TB or the TB is too disseminated or too severe, or it could be just because the patient is carrying so much pill load. There are so many drug interactions. There are so many adverse effects that the patient may not be compliant with the treatment, or patient may not be absorbing the drug as well. So there are so many different kinds of reasons why what is happening, and we have to first understand whether the virus. But we have to, before our approach should be that we should see whether it is just clinical failure or is it a clinical failure along with the immunological failure, so that we can approach the patient, each and every patient, the right way. That's what I feel. And in this case, I think the only thing, if Dr. Ashish would like to ask, I think there was a when the HIV patients usually have extra pulmonary TB. So if we have a pulmonary TB case, I think there should be a more aggressive approach in getting the DSP or sample from somewhere. There were so many necrotic lymph nodes. Maybe there was some peripheral lymph node from which a DST sample could have been taken. So maybe that would have worked, and ruling out substance abuse. That's what I feel. That I think in pulmonary cases we have to be more aggressive in taking the CBNAT DST. So that's what I feel.
We have one more question, sir. If a patient is on ATT for abdominal cough, should we repeat a ultrasound at the end of the IP or at the 6 months of this treatment?
So if you have started the treatment based on the ultrasound, so in the ultrasound usually they specify some signs for TB and sometimes size of the lymph nodes. So at the end of 2 months, usually we get the ultrasound to see the decrease in the size of the lymph node. If it is not decreasing, then we should be more careful about that. It may be a MDR TB or something more. So we must do ultrasound at the end of 2 months if it is a if you are following the patient based on the ultrasound. So at the end of the IP, you should go for the ultrasound.
Thank you, sir. I answered the post-poll questions. So the first question was, all of the following are used as a follow-up tool for seeing the effectiveness of TB treatment, except the options were clinical and radiological features. Option B was sputum smear for AFP. Option C was AFB culture. Option D was CBNAT or TrueNAT. So the correct answer for the question is D, the CBNAT. Another question was, all are the true statements except, as per the NACO guidelines, if an episode of the TB occurs within 6 months of the initiation of the ART, it should be considered as a failure of the treatment. So the correct answer is statement A.
Dr. Tanweer, you were specifically asking about whether we should wait for the CT test for stopping the treatment.
Yes, sir. I want to
Okay,
know.
okay. So actually, your clinical parameters are now okay. Your
Yes.
X-ray is also improved,
Yes.
and but there is a no smear. Smear is not there. Smear negativity is not there. So you should get the smear also. If smear is negative, you should not wait for these CT scan, because X-ray, clinical feature, and smear become negative. Then you can stop the ATT.
Okay. Thank you, sir.
Okay.
Thank you, ma'am. And thank you, Dr. Jyoti.
Thank you, madam. Hope your all questions are answered today.
Yes. Thank you, ma'am.
Thanks.
I think with that we can close the session, and I would extend my thanks to our expert today. Thank you for the excellent session and clearing all the doubts in such a clear and pragmatic way. Thank you, Dr. Ashish. And these sessions will be on our YouTube, so that you can benefit it from whenever you have time. Please go back to it, so because it's not easy to imbibe everything at once. And we will it's always on our YouTube channel. Please do that. And thank you to Dr. Jyoti and everybody on the panel.
Thank you so much, ma'am. On behalf of my team, I would like to thank our case presenter who brings such interesting case for the discussion. I thank our case expert today, Dr. Ashish. I thank Dr. Ananya for moderating the session so well. And our audience, thank you so very much to attend the session. Thank you all.
Thank you. See you next session.